we'll be covering the chest, PA, and lateral. First, no relevant financial disclosures pertain to the content of this discussion. Our objectives are to cover technique, some basic and challenging radiographic chest anatomy, and provide a general approach to chest radiograph interpretation. Here are our selected topics, ranging from technique to normal anatomy. So first, in terms of technique, a PA radiograph is obtained with the anterior chest placed against the detector. X-ray beam passes from posterior to anterior, thus the PA name, and the X-ray is usually generated from a source that is placed greater than 6 feet away from the patient's chest to minimize the fanning of X-ray beams, which can lead to magnification. Patients are typically standing in position. The left lateral radiograph derives its name by the fact that the cassette is placed against the left side of the patient. A broad range of tissue densities exist in the chest, and therefore high KVPs are utilized to penetrate the chest and be able to optimally image the lung and mediastinum. There is a trade-off as bony detail is lost due to the high KVPs utilized for chest radiography. So let's take a look at the AP chest X-ray, which is usually obtained portably because patients can't stand erect. The X-ray passes from the anterior part of the chest to the posterior part of the chest, which is placed against the detector. The target film distance is usually less than 6 feet, and therefore there's greater magnification. And we can see here that the structures, particularly that are anterior, are magnified as the X-ray beams strike, and they have a longer distance to travel to the detector and a higher chance of fanning out to a greater degree than X-rays that strike more posterior structures, which also fan out, but the distance is shorter. And therefore the heart particularly is accentuated on the AP radiograph, which limits our assessment in terms of size. Lower KVPs are utilized because of limitations of portable units typically, and lower maximal MASs are also possible with portable radiographs. There are typically increased exposure times compared to PA radiographs, which lead to greater motion effects on portable chest X-rays. Here are two X-rays of the same patient obtained at different times, and we can see the portable X-ray provides less definition of the mediastinum because of lower KVPs utilized to acquire the images, and we can see by far better spinal detail in the retrocardiac regions. There is a way to identify if a chest X-ray has been obtained portably as opposed to PA, and this was described by investigators in the past, in which the AP technique enhances the joints of Luschka and the anterior and posterior vertebral aspects of the bodies. The PA radiograph, on the other hand, accentuates the posterior elements in the transverse processes, and this is how one can utilize these signs to differentiate the two projections. This is the manuscript that looked at these signs to determine if X-ray was obtained in the PA projection as opposed to the AP projection. The X-ray beams with the AP technique are more divergent and therefore hit the intervertebral spaces in tangent and therefore define these better than the PA X-ray beams, which are more aligned with posterior elements. And that's why we can see the posterior elements better on the PA radiograph. So let's talk about evaluating technique. The first aspect to consider is patient positioning, and the second, the degree of inspiratory volumes. The patient can be standing erect or slightly angled anteriorly or posteriorly. Erect positioning is implied when the first anterior ribs overlie the fourth and fifth posterior ribs or their interspace. Patients are more in the lordotic positioning, as in this example on the right, which is extreme lordosis. When the clavicles are raised off of the chest, we can see the curvature of the clavicles arcing towards the apex of the lungs, and the overall position of the clavicles are horizontal. This patient is in a slightly less lordotic positioning, and notice how the anterior ribs are higher than their expected overlap of the fourth and fifth posterior ribs. We can see that the shape of the cardiac silhouette changes in lordotic positioning. The cardiac apex is lifted off of the diaphragms, which usually overlaps. We can see pericardial fat underneath the left ventricular apex in the lordotic position. The antilordotic position is indicated when the anterior ribs are lower than expected, and we can see the anterior ribs are overlying about the seventh posterior ribs. There's also angulation of the clavicles to a greater degree than typical. And also note how the cardiac silhouette now overlaps the diaphragm. We can still see the cardiac border because the lung, in addition to the heart, are anteriorly located in relation to the domes of the diaphragm because the patient is leaning forward on the radiograph. In terms of long axis rotation, we first evaluate if the spinous process is centered between the clavicle heads. When centered, this implies that the patient is directly perpendicular to the X-ray beams and the film is well centered. In this case, there is rotation, and rotation is indicated by the side which has the wider spinous to medial clavicle head distance. In this case, the patient is rotated towards her left because of the wider distance. This schematic explains the concepts of rotation and why the clavicular spinous distance is greater. We can have a patient, as exemplified by this axial CT, lying against a detector but slightly rotated towards their left or looking up from their feet to their head. We can see how the anterior structures move in the direction towards which the patient is rotated, and the posterior structures move in the opposite direction. This creates a widened distance between the anterior clavicular head and the posterior spinous process, and this widened distance indicates the side toward which the patient is rotated. This rotation can create differences in density of the patient's soft tissues, right versus left. Certain mediastinal structures can be accentuated, particularly when the patient's rotated to the right. For example, the ascending aorta can be moved towards that direction and be thrown over the right lung, and it creates a enlarged mediastinal contour. Displacement of the dome of the diaphragm can occur, also something to be aware of. Here's an example of a patient slightly rotated to their right. Notice how the right cardiac border is no longer in its expected position, about a centimeter or two from the right paraspinal line. The cardiac silhouette appears more displaced towards the right hemithorax and also the right mediastinal border, and this is because these are anterior structures. The patient is rotated towards the right, and therefore they're thrown out more towards the right, and this is something to be aware of so we don't misdiagnose enlargement of mediastinal structures unnecessarily. So let's evaluate the degree of inspiratory volumes. Inspiratory volumes can be evaluated by the position of the diaphragms in relation to the ribs. There's no definite rule, but a rule of thumb is that the 10th posterior rib would overlap approximately the mid-hemidiaphragm in terms of the dome and the 7th anterior rib. The 10th posterior rib in this case is below the level of the dome of the diaphragm, and therefore this radiograph is of low inspiratory volumes. We can see the crowding of the vasculature. You can see the heart that is accentuated by the low volumes, and the mediastinum in addition is something to be aware of as compared to an X-ray of more normal volumes. So now in terms of diaphragms and fissures. The right hemidiaphragm in general is higher than the left by about a centimeter. The diaphragm should be seen behind the heart and run to the spine, as the diaphragms exist behind the heart and aren't silhouetted in these regions by the soft tissue of the heart. The diaphragms on the lateral radiograph can be differentiated using a couple of clues. The left hemidiaphragm has the heart sitting on the anterior aspect, and this silhouettes out the anterior aspect of the diaphragm. The lung can't touch any part of this anterior diaphragm, and this indicates that this is the left side. The right hemidiaphragm also is slightly higher typically, and is continuous through the cardiac silhouette because the heart tends to be more on the left side. We can use also signs of bowel underneath the hemidiaphragm to indicate which side is left or right, and also the ribs, which are magnified, particularly on the right in relation to the left ribs, because the X-ray is obtained typically in the left lateral technique with the left side of the chest adjacent to the cassette, and therefore the right ribs are magnified more than the left side given the greater distance from the cassette. And here we can see the right ribs have a slightly increased shaft thickness compared to the left side. They tend to project posterior to the left, but is not a reliable rule because of rotation. So looking at the shaft thickness is helpful, and these are the right ribs. The diaphragm on the right goes to and touches the back of these ribs, as opposed to the left side, ribs touching the left diaphragm. The fissures can be visualized on chest radiography as fine lines, and with the left major fissure with a more vertical orientation, as we can see on this reformat, compared to the right-sided fissures. This is a left major fissure which extends cephalad to about the T4 level, and we can see the right-sided fissures, the right minor fissure, and the major fissure with a slightly more horizontal position, which separates the lobes of the right lung, upper, middle, and lower lobes. An azygos fissure is created by the azygos vein, which incompletely descends to its expected location in the right tracheobronchial angle. This is a normal variant in which the lung is invaginated by the azygos vein, and therefore the fissure is comprised not of 2 layers of pleura, but rather 4, 2 of visceral and 2 parietal layers of pleura. This can be more medially located and also more towards the center of the lung in medial lateral aspect. So now on to the right upper mediastinal contours. The right upper mediastinum is created by the SVC, which gently curves towards the mediastinum. More inferior to this, the ascending aorta could potentially be the border-forming structure, particularly in older patients, or the SVC can be the border-forming structure. The cavoatrial junction is indicated by a gentle change in the curvature of the SVC where it joins the right atrium. The lateral radiograph shows the ascending aorta abutting the lung anterior to the mediastinum. As shown on this MIP image, we can see the ascending aorta creating part of the anterior interface of the mediastinum. Here's an example of an abnormal right mediastinal border in which there's convexity that projects over the hilar vessels. We can see on the lateral radiograph we fail to see that ascending aorta, and that's because there's a soft tissue mass interposed between the ascending aorta and chest wall, and a mass that obliterates the normal right mediastinal contours on the frontal radiograph. This interface is typically behind the interface of the SVC. It's created by lung abutting the right posterior lateral tracheal wall, and then there's air within the trachea that creates this stripe, and this is called the right paratracheal stripe, and it should be 4 millimeters and smaller. Enlargement is an indicator of adenopathy. At the inferior aspect of the paratracheal stripe is this structure, the azygos vein. This is the normal location in the right tracheobronchial angle, as we can see on this reformat with the azygos vein, which should not be larger than 1 centimeter in distance when looking perpendicular to the right mainstem bronchus. So this is a normal azygos vein. So let's discuss heart and valves. The heart on the frontal radiograph has its right border being created by the right atrium and the left by the left ventricle. The right ventricle does not form a border-forming structure on the frontal radiograph. The left ventricle leads to the ascending aorta through the aortic valve. On the lateral radiograph, we see the right heart structure of the right ventricle and its pulmonary outflow tract. The pulmonic valve, as on the sagittal reformat, is located in this plane, and we can see the pulmonary outflow tract leading to the main pulmonary artery, which can form the uppermost aspect of the interface of the mediastinum with the adjacent lung anteriorly. Notice how the left atrium is higher and the left ventricle forms the posterior inferior aspect of the cardiac silhouette. And we can see this on the sagittal reformat. Now, heart valves are important to understand where they're located, and with knowledge of the chamber position, we can understand where the valves are. The tricuspid valve is located between the right atrium and the right ventricle, which we don't see on the frontal radiograph, but we can see the right ventricle contour anteriorly. The mitral valve is next, and the blood flows from the left atrium through to the left ventricle, which forms the inferior aspect of the cardiac border. The aortic valve, which is replaced in this case, runs from the left ventricle out through the ascending aorta, and the aortic valve on the frontal radiograph is positioned more centrally than the mitral valve, taking blood from the left ventricle and pushing it out, allowing the blood to flow into the ascending aorta. The pulmonic valve is the highest valve, and this is because pulmonic valve is located between the RV outflow tract of the right ventricle and the main pulmonary artery. So it's pulmonary artery, mitral, and tricuspid valves. An axis drawn from the right inferior cardiac border to around the region of the left atrial appendage, which we'll discuss, can be helpful in determining whether you're dealing with an aortic or mitral valve, as they're very close to one another. The left upper mediastinal contours are created by the left subclavian artery and the aortic arch in the uppermost aspect. On the corresponding coronal reformats, we can see how the lung abuts the vessels in these regions. The left subclavian artery can also be visualized on the lateral radiograph. We can see here the tracheal air column, and we see this opacity crossing over the air column. This actually is a portion of the left subclavian artery after it arises from the aortic arch. The left subclavian artery is the last major aortic arch branch vessel, and we can see how this corresponds with volume rendering of the trachea superimposed on this volume rendered aspect of this left subclavian artery. And we can see the left subclavian artery here overlying the trachea. If we're looking from a lateral view, we can see how it overlies the tracheal air column. This next interface is inferior to the aortic arch and is this gently convex to the mediastinal contour created by lung abutting mediastinal fat. This region is called the AP window and can be affected by adenopathy and aneurysms given its location. Here is an example of an extreme example of the aorta and pulmonary artery in the AP window with adenopathy. So adenopathy elsewhere, and notice the convexity of the interface of the right mediastinum in the SVC region. This is SVC displaced by adenopathy. So convexity away from the mediastinum, indicator of adenopathy. So now on to the main pulmonary artery, which is inferior to the AP window. The main PA is convex to the lung or concave to the mediastinum. And as we can see here is the border forming structure on the frontal radiograph. The pulmonary arteries on the left can be seen emanating from this main pulmonary artery structure. So now on to posterior interfaces. These are interfaces of the lung with the mediastinum, and this is a key interface. This interface runs from the region of the azygos vein down to the lower thorax posteriorly. It's created by lung abutting the mediastinum and should be gently convex to the left in the upper aspect and gently convex or straight to the patient's right in the lower aspect. And this is the Azygoesophageal Recess. We can see on this coronal reformat the azygos vein and the esophagus, how they run near the descending thoracic aorta, and the lung abutting the mediastinum in the region of these structures, the azygos and the esophagus, creates this recess. When this recess is deviated, it indicates pathology in the subcoronal region and lower mediastinum. Now here's an example of the Azygoesophageal recess being deviated. We don't see it behind the cardiac silhouette, which has its interface here with the right lung, the cavoatrial junction, and we can see this corresponds with a large mass posterior to the heart in the region of the azygos vein and esophagus, and this was an esophageal mass, which was carcinoma. The esophagopleural stripe is created when you have the azygoesophageal recess, but there's also air in the esophagus, creating the appearance of a stripe on the right, as in this case. This posterior interface is where the lungs on the right and left touch each other above the level of the aortic arch. This is called the posterior junction line and should be a fine line, and we can see on the coronal reformats the lungs abutting each other. It ends at the top of the aortic arch, which is more of a posterior structure, and we can see how it extends high up, even above the level of the clavicular heads, and that's because lung exists above the level of the clavicles posteriorly. The scapula can be seen on the lateral radiograph. They project over the spine or the space between the trachea and the spine sometimes, and they have an edge which corresponds with the blade of the scapula, as shown on this volume rendering in the sagittal view. And this is what we can see on the lateral radiograph and something to be aware of. Now in terms of the anterior and lateral interfaces, the anterior junction line, which is the corollary to the posterior junction line, begins lower. It begins at the level below the clavicles where the lungs come together and touch, anterior to the mediastinum as shown in this volume rendered image. The clavicles are higher than the anterior junction line because lung exists anteriorly below the level of the clavicles and not above it anteriorly. The cardiac incisura is the pericardial fat where it butts the lung on the lateral radiograph. This creates an opacity that oftentimes projects over the anterior inferiormost cardiac silhouette on the lateral radiograph. So let's talk about retrosternal and parasternal stripes. Retrosternal and parasternal stripes derive from the lung abutting the osseous structures anteriorly. These are higher than the cardiac incisura, and we can see the undulation of both costochondral cartilages of the ribs where they abut the adjacent lung, and this is the parasternal stripe. The retrosternal stripe is created by the soft tissue or fat behind the sternum abutting the adjacent lung, and is more difficult to see. There are two parasternal stripes that can be created and one retrosternal stripe. Here's an example of deviation of these lines. We can see this focal convexity, two convexities actually that correspond with two internal mammary lymph nodes that are enlarged. We can see on this sagittal reformat the correlation of these convexities with the region of the internal mammary artery and vein, which have adenopathy, and see how it abuts the adjacent lung. So now in terms of hilar vessels. The hilar vasculature is generally higher on the left than on the right. The rule of thumb is about a centimeter in terms of distance between the two vessels. If there is an equal level to the vasculature, one has to wonder if there's pathology that's sitting on top of the right hilar vessel that would make the hilar to be equal in height, or perhaps there's abnormality that's pulling down the left hilum so that it's equal height to the right hilum. One can see how the left hilar vasculature is higher than the right on the lateral radiograph, which it courses, the left pulmonary artery courses over the left upper lobe bronchus, and the right pulmonary artery is anterior to the right-sided bronchi, and thus the elevation of the left vascular pedicle relative to the right vascular pedicle. So on this lateral radiograph, we see the right main pulmonary artery that is projecting anterior to the airways, the left upper lobe bronchus and the right upper lobe bronchus. We also see the higher left main pulmonary artery and the interlobar pulmonary artery, and notice how the left lower lobe pulmonary arteries in general are more posterior than the right lower lobe pulmonary arteries. This can be demonstrated on the MIP image, in which we see the interlobar pulmonary arteries and the left lower lobe pulmonary arteries that project posterior to the right side of pulmonary arteries. We need not forget about the pulmonary veins, which have a more horizontal course and head directly towards the cardiac silhouette. The pulmonary arteries are more lateral and have a more vertical orientation, as shown in this MIP image with the horizontal pulmonary veins and the vertically oriented pulmonary arteries. So let's talk about airways. The trachea can be seen on chest radiograph and gives rise to right mainstem and left mainstem bronchi. The left mainstem bronchus is longer, the right shorter. The left is curved and the right tends to lead to a very horizontal right upper lobe bronchus. Bronchus intermedius can oftentimes be seen on X-ray, and the lower lobe and middle lobe bronchi overlap oftentimes on the frontal radiograph. The left upper lobe bronchus arises from the left mainstem bronchus, and the lingular airways and the left upper lobe proper airways arise from that. The left lower lobe bronchi oftentimes overlap the lateral aspect of the cardiac silhouette on the left side. We can see how the right upper lobe airways are at a higher level than that of the left upper lobe airways. This enables us to interpret the lateral chest X-ray, where the left upper lobe bronchus is at a lower level than the right. We can see the left upper lobe bronchus more often because the left pulmonary artery courses over the airway, and the right pulmonary artery is located more anteriorly near the region of the left upper lobe bronchus on the lateral. We can see right middle lobe bronchus on the lateral radiograph more readily, heading anterior after it rises off of the bronchus intermedius, and the lower lobe airways on the right are located posteriorly and typically a little bit more anterior to the left-sided airways, and that's because the heart is on the left and perhaps displaces some of these airways more posteriorly. The lingua is typically difficult to see on chest radiograph. The intermediate stem line is something of a landmark that's helpful in assessing the higher structures. We can see on this sagittal reformat how we have the right upper lobe bronchus, and then after that, the bronchus intermedius is seen. This bronchus intermedius can be seen as an elongated air-filled column, and there's a line that actually demarcates the back of the bronchus intermedius from the adjacent lung. And this has been called the intermediate stem line. This typically crosses through at least a portion of the left upper lobe bronchus, which is visualized here. If we superimpose the two images that we just spoke of, we can see how the right-sided airways, the right upper lobe, the bronchus intermedius, and the intermediate stem line course through the left upper lobe airways. The back of the left upper lobe airway has been termed the retrobronchial line, and the intermediate stem line passing through the left upper lobe bronchus. Here's an example of adenopathy in the mediastinum and Hila regions, in which there are nodes behind the bronchus intermedius, and this creates increased density in the region of the bronchus intermedius. Infrahilar window can also be opacified when there's adenopathy. The infrahilar window is typically the airspace between the right middle lobe bronchus and right lower lobe bronchus, and this region can become opacified when adenopathy is present in the hilar regions. Only normally there are small vessels running through this area. And here's an example of bilateral hilar adenopathy. There's also mediastinal adenopathy in the AP window, but we can see the soft tissue density in the infrahilar window, which we don't see anymore, and this is an indicator of adenopathy. So let's review the lungs. This is important to understand so we can localize pathology to different areas of the thorax. The right upper lobe extends from the lung apices to the minor fissure anteriorly. Posteriorly in the right upper lobe ends at the right major fissure, which has an oblique course. The lung above the level of the clavicles is posterior in the thorax, as anterior lung doesn't exist above the level of the clavicles. So let's take this example of this lung mass, which is seen above the level of the clavicles. And this correlates with its more posterior location, and that's because lung is primarily at the level of the clavicles in the posterior aspect of the chest. This lateral radiograph shows the level of the clavicles and shows how the apex of the lung arcs more posteriorly and in the mid-thorax as opposed to anteriorly. We can see the middle lobe, which is located anteriorly and abuts the right heart border and also overlaps at a certain degree. And this is why lesions can project over the cardiac silhouette and be in the right anterior lung. Here's an example of right middle lobe pneumonia affecting the lateral segment. We can see the minor fissure and the major fissure that's outlined by consolidation. Here's the right lower lobe, and we can see that extends quite far up into the thorax, so lesions in the mid-lung could be within the upper or lower lobes. Another key aspect is to remember that the lung extends posteriorly behind the dome of the diaphragm in this more dense area. And we can see the right major fissure correlating with the course of the major fissure on the frontal radiograph. Here's an example of a nodule which is projecting below the level of the diaphragm. Notice how it's sharply demarcated, indicating it's surrounded by air. This corresponds with its more posterior location because this is where lower lobe exists. And we can see how it's projecting below the diaphragm on the lateral radiograph. Just emphasizing that we should be scrutinizing behind the diaphragms in addition to over the cardiac silhouette in many locations that can hide lung lesions. And here is the correlating CT. The left upper lobe occupies majority of the upper to lower distance above the level of the diaphragms. We can see the upper lobe on this coronal reformat in terms of its extent, and it comes pretty close to the left hemidiaphragm. So therefore, lesions that fall within a majority of the mid to lower hemithorax could well be within the upper lobe. Again, the posterior aspect and mid aspect of the lung is probably what's above the level of the clavicles. And here's the schematic again showing how the lungs are higher posteriorly and how the upper lobes can extend anteriorly and inferiorly. So the left lower lobe extends from the upper to mid hemithorax to the lower thorax beyond the level of the dome of the diaphragm. The darker areas correspond to areas probably only in the lower lobe, extending medially to the border of the spine and beyond the top of the dome of the diaphragm. We can see, as on this schematic, overlaying a lateral chest x-ray, how the lower lobe extends beyond the level of the dome of the diaphragm and abuts structures in the spine behind the heart. Now, Costophrenic angles should always be sharp and be acute in configuration, both on the frontal and also the lateral projections. Here's an example of blunting, which would indicate a pleural process. The blunting is elongated, and we can see that this is a meniscus created by pleural effusion. Notice there's also separation of the lung from the inner margins of the ribs, another sign of pleural disease. And this patient had mesothelioma and asbestos-related pleural disease. The mesothelioma was on the right and manifested as pleural thickening in addition to pleural effusion more inferiorly. A systematic approach is key for accurate chest X-ray interpretation. This can entail scrutiny of the X-ray in terms of the periphery of the image, paying attention to the osseous structures, the abdominal structures and shadows, in addition to the periphery of the ribs and scapula. Attention to the central region, which includes the trachea and the vertebral column, and then all the mediastinal contours that we discussed in terms of what's expected. The Azygoesophageal Recess is an important landmark to always be visualizing on a PA and lateral radiograph, sometimes not well visualized on portable radiography due to technique. Attention to the lungs can be made by panning through the entire area of where lung would be expected including behind the diaphragms, overlying the cardiac silhouette, and particularly in the higher regions where there are a number of vascular structures in which lesions can be overlooked. And lastly, a second look at the apices where a number of nodules can be hidden by overlapping osseous structures. This search for hidden spots could aid in identifying lesions that are overlapping other distracting structures, and it is important to account for all findings that cannot be attributed to by normal anatomy. A lateral chest X-ray can be approached in a similar manner. Scrutiny of the anterior chest wall, the sternum, the upper abdomen, posterior ribs can be made in addition to the trachea. And then evaluation of the lungs and all the normal interfaces, including the hilar contours, pulmonary artery, the right pulmonary artery, and the infrahilar window. Lesions that are overlooked oftentimes overlie the spine because of the number of osseous structures in addition to the cardiac silhouette, so attention to these regions is very useful. So in summary, an understanding of a patient positioning really aids in interpreting the chest radiograph and understanding how mediastinal and cardiac structures change with rotation. The knowledge of normal interfaces is really essential for identifying pathology on chest X-rays, and a systematic method for approaching a chest X-ray that's followed every time will help minimize failure of detection.